Welcome back, everyone. Grab your favorite highlighter and put on your auditor hats, because today I'm going to be your enthusiastic E&M compliance mentor. We are jumping right into part 9 of our series, Evaluation and Management Coding. Specifically, we're focusing on mastering medical decision-making in diabetes care. We're going to break down exactly how to accurately score these office visits using the 2023 guidelines, turning what can honestly feel like a confusing gray area into pure black and white compliance. Let's dive right in. Here's our roadmap for today's explainer. We'll start with a 2023 E/M guidelines overview, then escalate through the charts, straightforward MDM, low MDM, moderate MDM, high MDM, and wrap it all up with a final review.
All right, kicking things off with Section 1, our 2023 E/M guidelines overview.
For this session, we are looking strictly at outpatient visits. I'm talking about your 99202 through 99215 codes. Now, under the 2023 updates, history and physical exams are based on what is medically appropriate, meaning they no longer dictate your code level. What a relief, right? Instead, your code is driven either by the total minutes spent that day or by the level of medical decision-making, which we just call MDM. And while you absolutely can score visits based on time, today's audit focuses purely on mastering those MDM pathways. Okay, if there is a single number you need to literally burn into your memory as an auditor, it's this one, 2. This is the absolute golden rule of auditing E&M levels. To score any specific level of medical decision-making, we must meet 2 out of the 3 key elements. You don't need all 3, but you absolutely, for sure, must have 2.
So what are those 3 elements? Well, think of them as the 3 columns on our auditor's rubric. Column 1 is the number and complexity of problems addressed during the visit. Column 2 is the amount and complexity of data reviewed and analyzed. And column 3 is the risk associated with the patient management. We're going to use this exact 3-column rubric to evaluate every single patient chart today.
Real quick before we open our first chart, I really want to highlight this crucial guideline regarding that second column, the data analyzed. The absolute keyword here is unique. Each unique test, order, or document counts. Precision in counting these unique tests is vital for compliance. You can't just group a bunch of lab tests together generically, right? We have to look at each unique order to give the provider the correct credit for the cognitive work they're actually doing. Moving right along to Section 2, straightforward MDM. Let's open up the first patient chart on our desk and review a baseline clinical encounter. The patient presents to the office to review a recent HbA1c test. The result is 5.9%. The physician confirms a diagnosis of prediabetes, and the treatment plan is just advising the patient on dietary modifications. It's a very standard, everyday scenario. That's going to be coded as either a 99202 for a new patient or a 99212 for an established one. Let's actually audit it. This brilliantly illustrates our 2 out of 3 rule in action. Looking at the rubric under problems addressed, we have one minor problem. That's the prediabetes. So that meets the straightforward criteria. For data, it's minimal. We're just reviewing a previously ordered lab. And for risk, dietary modification carries a minimal risk of morbidity. Because we hit minimal problems and minimal risk, we perfectly satisfy our 2 of 3 rule for a straightforward MDM level. Excellent job.
Next up is Section 3, where we step it up a notch to low MDM.
Here is our second chart, and we're moving one step up the complexity ladder. We've got a stable, chronic type 2 diabetes patient who has been on insulin for the past 6 months. They're just here for a routine checkup, and the physician orders an HbA1c test. Again, this is an incredibly common presentation in primary care and endocrinology, and it typically scores out to a 99203 or a 99213. Let's unpack this together. Under the problems column, we have one stable chronic illness, the type 2 diabetes. That perfectly hits the low threshold for problems. Looking at data, the physician ordered a unique test, the HbA1c. That right there satisfies the data element for low complexity. And for risk, managing a stable patient generally carries a low risk of morbidity. We actually met all 3 columns here. But remember, just managing that stable chronic illness and ordering a unique test easily secures the 2 required elements we need to confidently stamp this chart as low MDM. All right, Section 4. Time to raise the stakes with moderate MDM. Pay really close attention to the details here because the clinical picture is getting a bit more entangled. The patient has diabetes with a cataract. They're here to review lab reports, which show uncontrolled blood sugars. So the physician prescribes a new dose of insulin to manage this. On top of that, a decision is made that cataract surgery will proceed,
but only once that blood glucose level is brought back into a normal range. This multi-layered scenario is a classic 99204 or 99214 visit.
Let's break down exactly why this jumps to moderate. Under problems, we have a chronic illness, the diabetes, with an exacerbation because of that uncontrolled blood sugar. That is a moderate problem. For data, we have the review of the labs, but really look at the risk column here. Adjusting the insulin dose counts as prescription drug management, and planning the cataract surgery constitutes a decision regarding minor surgery with identified patient risk factors. Either one of those alone solidly lands the risk element in moderate territory. So, we have a moderate problem and moderate risk. That is our 2 out of 3. We can confidently code this a level 4. Finally, Section 5. We've arrived at the top of the MDM ladder, high MDM. Opening our final chart, we see a very severe, high-stakes clinical presentation. We have a patient with pancreatic cancer admitted for chemotherapy. Unfortunately, they've developed acute drug-induced diabetes as an adverse effect of that treatment. Because of the sheer severity of this, the patient requires intensive monitoring, and a battery of blood tests are ordered. This absolutely warrants a 99205 or 99215 code.
Let's apply our rubric one last time. Under problems, this acute drug-induced diabetes in a chemotherapy patient represents an illness that poses a severe threat to life or bodily function that perfectly hits the high problem threshold. Data involves ordering multiple tests. But let's look at risk. The need for intensive monitoring due to the toxicity and systemic impact of the drug-induced diabetes firmly establishes high risk. We have a high problem and high risk. 2 out of 3 met. This chart brilliantly and compliantly supports the absolute highest level of medical decision-making.
Bringing us to Section 6, our final review. What an incredible auditing session we've had today. Remember, scoring EM levels is not a guessing game. Use the rubric, count your unique tests, evaluate your risks accurately, and always let that 2 out of 3 rule guide your compliance. By breaking the encounter down into problems, data, and risk, you take all the emotion out of coding and replace it with solid black and white rules. I hope you feel super empowered to tackle your next batch of diabetes charts with total confidence. But tell me, what's the most complex gray area patient chart you've had to audit lately? And knowing what you know now, would the 2 out of 3 rule have saved you some headache? Let me know your thoughts. Thank you so much for joining me on this explainer today. If you found this helpful, please like, share, and subscribe to Decode Healthcare with Harshal.